Okay, doctors, we are live now.
Okay.
Yeah, good evening and welcome to the expert crosstalk on empagliflozin, multi-mechanisms, multi-indication, and multi-benefits. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which would bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to EMPA-REG trial, does SGLT2 inhibitor may be considered as an important drug for HFrEF? For this, let me introduce today's speakers. Today's speakers are Dr. G. Manohar and Dr. N.K. Narayanan. And I am your moderator, Dr. Shavik. Dr. N.K. Narayanan is a consultant endocrinologist at Apollo Hospitals, Chennai. Dr. Narayanan has several national and international publications in his credit, and he is also a journal editor or reviewer in various journals, and also associated with various research projects in India and UK, and received various prestigious awards till date, and also presented various papers in national and international conference and associated with research and ethics committee of Apollo Hospitals. I welcome Dr. Narayanan in this expert web talk. Our next speaker is Dr. Manohar. Dr. Manohar is a consultant cardiologist for his Manohar Hospital, Chennai. Manohar has got a special area of interest at coronary angiography, angioplasty, primary elective PCI, permanent pacemaker implantation, and many more. Dr. Manohar has several national and international publications in his credit, and I welcome Dr. Manohar in this expert web talk. And I'm handing over the session to Dr. Narayanan to start with the presentation.
There's a problem with slide sharing. I'm not able to see the screen. Can somebody share the slide from your end and I can go through?
Vinay, can you share the slides endocrine perspective from the starting?
Just a sec, doctor.
Yeah. Vinay? Yeah. No, endocrine perspective.
Endocrine, starting. Not this one. Endocrine perspective. It's not there.
Doctor, this presentation is only shared with me. I'll just check with another one.
Okay, yeah. Dr. Narayanan, can you just try once sharing screen?
Sorry?
Can you just try once to share
Yes, I think I've updated my software. I'm not able to see the share content with screen.
No, share screen is there in the Zoom, this thing?
No, I've got the share content. Normally I get a share screen, which I'm not able to see here now.
Just reduce it. Just, yeah. Reduce. Are you getting that share screen button? Can you see in the Zoom?
No, I can see the share content. This is from iPad I'm sharing. But normally it comes up with under share content, it says screen, which is where I share. But I'm not able to see that share screen now.
Okay. Vinay, you got the presentation? Because I have some presentation, old one. So I don't know whether same thing or not.
Dr. Shavik, if you have got it, you can share it from your end, can you?
Yeah, I'm seeing whether the same presentation or not. Just a moment, please. I'm sharing the screen, Dr. Narayanan. Can you please check it, the same presentation?
Yeah.
The same?
Yeah. Well, at least this part is the same.
Yeah, fine. So if you don't mind, can we start it?
We'll start. If there is any problem, I'll let you know.
Yeah,
Good evening, everybody. Sorry about the delay in starting the presentation. Anyway, this talk is about the SGLT2 inhibitors. As we all know, the field of diabetes has come a long way, right from the era of having only metformin and sulfonylurea, which used to be the only oral anti-diabetic medications, apart from which insulin we had. This was the era of UKPDS and DCCT, the two landmark trials which we have had in the field of diabetes. The only drug in those points, at those points, which showed a mortality benefit was metformin. Apart from that, the subsequent medications which were introduced into the field of diabetes did not have any mortality benefit, metformin being the only drug. That barrier has been broken by the SGLT2 inhibitor. After metformin, the next agent which has shown a clear cardiovascular mortality and overall mortality benefit in patients with type 2 diabetes is the SGLT2 inhibitors. So I'm going to focus on the endocrine and diabetes perspective of SGLT2 inhibitors, following which our colleague will focus on the cardiovascular aspect. Now, if we look at the SGLT2 inhibitor, just to give a basic background to this mechanistic aspect of this molecule, SGLT2 is a receptor which is present in the proximal convoluted tubule of the kidney. And as we all know, from the proximal convoluted tubule, 60 to 70% of the glucose that is filtered through the glomerulus is reabsorbed. Now, we have seen that in people with type 2 diabetes, this SGLT2 mechanism is upregulated. Therefore, there is too much of this glucose which is getting reabsorbed from the proximal convoluted tubule. Therefore, this is thought to be one of the pathogenetic mechanisms, apart from the insulin secretory defect and insulin resistance defect. Now we come to know of many more mechanistic aspects which lead on to type 2 diabetes, one of which is this SGLT2 upregulation. Therefore, this theory that SGLT2 upregulation is increasing the glycemia in people who already have a high sugar values is what led to the discovery of this molecule SGLT2 inhibitor. Therefore, by inhibiting the SGLT2 receptor, the reabsorption in the proximal convoluted tubule of the glucose is inhibited. Therefore, it gets chucked out into the urine, thereby reducing the glycemia. It's anticipated, glucose being a molecular, as in an osmolar substance, when the glucose is chucked into the urine, it is followed to an extent by a diuresis as well. Now, this combined effect of the glucose and the water being chucked out into the urine has got multiple benefits, either direct or indirect. There are studies which are ongoing to see whether there are any other novel pathways which contribute to the pleiotropic effects that we see with SGLT2 inhibitors. But as of now, what we understand is because of this molecular mechanisms of the action of SGLT2 inhibitor, the add-on benefit, as we all know, SGLT2 inhibitor through its diuresis, natriuresis, and glucose reduction, it decreases various metabolic parameters. As we all know, it decreases the weight, and any weight reduction achieved through any other mechanisms, whether it's diet and lifestyle or through medications, definitely will have its knock-on effect, as in beneficial effect on the metabolic parameters, which is what we see with SGLT2 inhibitors. As we can see from the diagram here, it decreases the weight, it decreases the visceral adiposity, there it decreases the blood pressure and the arterial stiffness, the albuminuria decreases, the lipid profile becomes a bit more favorable, there is a reduction in oxidative stress, and possibly there could be a decrease in the sympathetic nervous system activity. So we can see that there are multiple knock-on beneficial effects of SGLT2 inhibitors just due to the action, the mechanism of action of this molecule. But as I said, there are studies which are ongoing to see whether there are any other novel mechanisms which are involved in this. Next slide. The beneficial effects, if we look at the SGLT2 inhibitors in terms of the treatment for heart failure, when we look at the other medications which are used in the treatment of patients who have got ischemic heart disease or heart failure, AC inhibitor, ARB, beta blockers, diuretics, there are many other molecules which we use in the treatment of heart failure. Now compare this against the SGLT2 inhibitors. We go row by row. Some of the molecules which acts via natriuresis, the classical being diuretic, SGLT2 inhibitors has got that mechanism. The cardiorenal physiology, the kidney protection by certain molecules like AC inhibitors, AR2B are very well known. Similar to that, the EMPA-REG renal outcome study, etc., showed that SGLT2 inhibitors have got a favorable profile on the kidneys. Because of its diuretic effect, it decreases both the preload and afterload on the heart, thereby decreasing the LV wall stress. That also the SGLT2 inhibitor has got a favorable mechanism of action there, and also it decreases the interstitial edema. So we can see that compared to multiple other agents which are used in the treatment of heart failure, the SGLT2 inhibitor ticks most of the boxes, what we can see here. Next. This molecule was launched only 6-7 years ago. The research was going on prior to that, but the fact that it came into clinical usage like 6-7 within a decade, let's say, the number of publications are innumerable with each of these molecules which we have got in the market now, whether it's dapagliflozin, canagliflozin, empagliflozin. Each of these molecules has got its own set of randomized controlled trials. The strength for the evidence behind these molecules just comes from these trials, which we will see. Next slide. So this diagram just explains what I was telling earlier, that SGLT2 inhibition in the proximal convoluted tubule leads on to increased urinary glucose excretion and an osmotic effect. Next slide. If you look at the pharmacological properties of the available SGLT2 inhibitors, the EMPA, DAPA, and canagliflozin predominantly, the therapeutic dose ranges from 10 to 25 for EMPA, DAPA 5 to 10, and canagliflozin 100 to 300. And each of these molecules acts 24/7. Therefore, these molecules can be given as once a day. The peak plasma concentration is achieved within a couple of hours. It's got a good bioavailability, about 60 to 70%. The primary mechanism of action is glucuronidation, and there is no active metabolite post this active molecule. And the hepatic to renal excretion ratios differs from each of these molecules. For example, the empagliflozin, almost 50% of that is excreted via the liver and 50% through the renal, whereas for DAPA, a renal excretion, and cana mainly a hepatic excretion. Now, when we talk about the SGLT2 inhibition, it is also important to look at the other side, which is the SGLT1. SGLT1 is a receptor which is present in the gut, which helps in the absorption of glucose from the gut. Now, when we talk about specific SGLT2 inhibition, we want these molecules to be more selective on the SGLT2 compared to SGLT1. And that's exactly what these molecules provide, the EMPA and DAPA being more selective on SGLT2 to SGLT1 compared to the canagliflozin, and giving a glucose excretion rate which is about 70 to 80 grams per day with the higher dose, that is 25 milligrams of EMPA, 10 milligrams of dapagliflozin. Next slide. So as anticipated, the HbA1c reduction with any of these molecules, specifically we are looking at empagliflozin here, is very pronounced. Either we use this as a monotherapy, as we can see from the first diagram here, first bar diagram here, there is a significant reduction of the HbA1c for about 0.8%. Or when you combine this with other molecules, metformin, pioglitazone, or a combination of metformin, sulfonylurea, or insulin, whichever way you look at the data, whether it's as a monotherapy, as a combination therapy, the beneficial effects are pronounced on the glycemia. Next. Next slide. Yeah. So because of the diuretic effect and maybe due to other unknown mechanisms, there is a reduction in body weight. I'm sure people who have been using SGLT2 inhibitors, that is our experience, clinical experience as well. Most patients lose a significant amount of weight. In practice, it could be ranging from 5 to 7 kilograms. By data, looking at the average weight loss through the RCTs, it's about 3 to 4 kilograms. But we need to see that this is an average weight loss, not an absolute weight loss in each individual patient. But this weight loss can be seen as sustained with a monotherapy, or the agents which we generally think would increase the weight, like sulfonylureas, pioglitazone. Even in combination with these agents, the effect of weight loss with SGLT2 inhibitors, empagliflozin, is sustained. Next. Thereby, because of the natriuresis and the diuresis, there is a reduction in a preload and the afterload on the heart. Therefore, it's anticipated that it will have an effect on the blood pressure on a beneficial way, which is a reduction in systolic blood pressure and a reduction in the diastolic blood pressure too. Again, the data speaks about whether it is used as a monotherapy or as a combination therapy. Next. Now, it's just not the data which we look at as an average systolic blood pressure weight reduction. This is an ambulatory blood pressure monitoring which was done over a 12-week time period. And this tells us, if we look at the data at the top, which is at the baseline, the systolic blood pressure, mean systolic blood pressure in the placebo arm, in the empagliflozin arm, and the empagliflozin 25 milligram arm are all just overlapping each other. Whereas if we look at week 12, which is such a short time duration, in 3 weeks time duration, the curve completely separates out from the placebo. Whether you're using EMPA-10 or EMPA-25, there is a significant reduction in the systolic blood pressure compared to the placebo. Next. And this as well holds true for the diastolic blood pressure as well. Again, this is the ambulatory blood pressure monitoring over a 12 weeks time period. Next. Now, this is a change in lipid profile. As I said earlier, any reduction in body weight with the visceral adiposity going down, you would expect a beneficial metabolic effect, including the blood pressure, the cholesterol, etc. And that's exactly what we anticipate with these molecules here. There is an increase in the HDL cholesterol level, and the LDL to HDL ratio, there is not much of a significant difference. Although there is a small increase in LDL cholesterol level, it is compensated by the increment in the HDL, thereby the LDL to HDL ratio does not change. Next. So this is a busy tabular column. Essentially, this is looking at the effect of SGLT2 inhibitor on glucose control, body weight, and systolic blood pressure when it is used as a monotherapy or when it is used as a combination therapy with metformin, sulfonylurea, DPP-4 inhibitors, or GLP-1 receptor agonists. And as we were looking through this data in a bar diagram format earlier, the data across the board, including the different RCTs which we have highlighted here. And as we can see, for example, the first 2 rows indicates the monotherapy. There were 10 randomized controlled trials with monotherapy with empagliflozin with around 2,800 patients. The mean HbA1c reduction of about 1.56% and mean body weight reduction of about 0.32 kilograms per meter square. Sorry, the BMI reduction. And likewise, this is the data for the monotherapy. But when we look at this in combination with metformin, sulfonylurea, and other agents as well, there is a beneficial metabolic effect with SGLT2 inhibitors. Next slide. This is the pooled safety data and the tolerability data. And it's essential when we look at new molecules, we look at the adverse events that can happen. And one can imagine that because there is an increased glucose excretion in the urine, you would anticipate there could be genital infections, especially fungal infections, which is what most of the studies with SGLT2 inhibitors have shown. We can see how we can prevent or lessen the risk of getting these genital infections. Now, this data looks at, compared to the placebo, how were the adverse events which led on to the discontinuation of molecule, and how were the serious adverse events. If we look at any adverse events, the number of adverse events is actually lesser compared to the placebo. When we look at the adverse events leading to discontinuation, there is definitely no significant difference between placebo and the empagliflozin, and patients with serious adverse events are also not there. But as I told you earlier, next slide, the minor side effects which we can anticipate because the glucose gets chucked into the urine are the incidence and prevalence of urinary tract infection and genital fungal infections. So we can see from the tabular column here that the urinary tract infection was slightly more with 25 milligrams of empagliflozin, but it was almost equivalent between placebo and EMPA 10 milligram. If we go down the row at 1, 2, 3, 4, 5th genital infections, where we can see that there is a significant increase in genital fungal mycotic infections, especially when people get started on the SGLT2 inhibition. So how to prevent this? Make sure that we give an instruction that this molecule chucks out glucose into the urine. Therefore, they are at a slightly higher risk of developing a mycotic genital infection. Therefore, I generally advise my patients to make sure they take adequate water and have a proper genital hygiene. Some simple measures like this would decrease the incidence and prevalence of fungal infections, the mycotic infections. If at all patients are prone for this, what we see is if it is just one-off infection, especially let's say the glucose level is high, they get started on SGLT2 inhibition, there is an increased glucose excretion in the initial start period. Let's say they get started now, maybe for the first 2 weeks to 1 month time period, there is an increased glucose excretion into the urine, during which time the patients may be more prone for the mycotic infection. So during this time period, if they do develop any symptoms, we can give them antifungal medications which clears up the infection. And once the glucose level comes back into the normal range, the plasma glucose levels, then the amount of glucose which gets chucked into the urine decreases. Therefore, we may not see a recurrent fungal infection in these people. There may be some individuals who may develop some recurrent infections, and if it warrants stopping and changing over, then we have to go by that. Next. Now, EMPA-REG outcome trial was landmark trial in the field of diabetes. And this was a trial, a randomized controlled trial, which was done very meticulously. What they did was they took patients with type 2 diabetes at high cardiovascular risk. The high cardiovascular risk was defined as in patients who already have had an MI, or patients who have had a cardiovascular disease in the form of heart failure, or an obstructive coronary artery disease. They randomized these people into 3 arms: placebo, empagliflozin 10, and empagliflozin 25 milligram. And they looked at a composite primary endpoint of combined cardiovascular mortality, non-fatal MI, and non-fatal stroke. And they also looked at other outcomes like the renal outcomes, which we see in this slide here. We will look at the cardiovascular outcome slightly later, but the renal outcomes from the EMPA-REG outcome trial showed that the incident or worsening nephropathy, the progression to macroalbuminuria, or the composite renal outcome which were looked at in this particular study, were all much better with empagliflozin compared to the placebo, and these were all statistically significant. This is anticipated given the mechanism of action of these molecules. And next slide. So they concluded that in patients with type 2 diabetes and high cardiovascular risk, empagliflozin given in addition to standard of care, which means the patients who were taking the previous medications were continued on those medications, but added on with empagliflozin, compared to the placebo, it reduced the heart failure, hospitalization, the CV death, and the benefits were consistent with and without heart failure at baseline. That means people who already had heart failure or people who did not have heart failure at baseline, both of these groups benefited from empagliflozin. Next slide. Now, this is the hazards ratio that we are looking at with EMPA-REG outcome. This was a 3-point MACE and CV death data that we are looking at. When we look at the primary composite outcome of 3-point MACE, the hazards ratio was favorable. It is about 0.86. And when we look at the individual components, The favorable 3-point MACE was derived mainly from the CV death and non-fatal MI. The non-fatal stroke, numerically, it was slightly more in the placebo arm. Next. Now, the interesting bit in the EMPA-REG outcome trial, which everyone was surprised at, was the time to derive benefit out of this molecule, to see the cardiovascular benefits from this molecule was very quick. If we look at the EMPA-REG data, the primary composite outcome and the heart failure data, etc., the benefits charts as early as 6 weeks time duration. People who have looked at the publications will know that the graph, the bar, the diagram charts diverging as early as 6 weeks time duration. So the early separation of the curves between the placebo and the empagliflozin arm surprised everybody. And the final outcome showed that there was a reduction in the risk of heart failure, CV death, and the composite outcome, therefore. And all these outcomes were seen within weeks after treatment initiation in the EMPA-REG outcome. Next. Yeah. So this slide tells you how early did the benefits chart. Now, compared to the placebo, when we look at the risk reduction for heart failure, it started almost on day 17. The hazards ratio and the p-value were significant from day 17 for heart failure. And when we look at CV death and heart failure as a combined data, then the benefit started by day 27. So what we can see is just within a month of starting the empagliflozin, due to whatever mechanistic aspects we are looking at, the cardiovascular death as well as the heart failure improved significantly, and that too very quickly within the first few weeks of starting empagliflozin. Therefore, when we look at the data for the entire duration of the study, it's not a surprise that the overall heart failure, hospitalization due to heart failure, and the CV death all decreased with empagliflozin compared to placebo. Next. Now, EMPRISE. So what we saw was the EMPA-REG, which was a designed study, randomized controlled multicentric study. EMPRISE was a study which was looking at the real world data. Retrospectively, they looked at 2 different databases in US, and what they compared the people who were put on empagliflozin compared against people who were put on DPP-4 inhibitors, majority of whom were on sitagliptin, and they were not comparing the glycemic reduction, which might have been equivalent and proportionate in each of these arms, but they looked at a huge volume of data, almost like 39,000 matched pairs of individuals between empagliflozin arm and DPP-4 inhibitor arm. And what they showed was it just not against the placebo alone, but even against DPP-4 inhibitors arm, the heart failure reduction was significant. The myocardial infarction, the myocardial infarction and stroke did not show any significant difference, but there was the all-cause mortality was more in favor of empagliflozin, primarily due to the reduction in heart failure. And we can see from the data from people who have had type 2 diabetes that it is not only the obstructive coronary vascular disease which causes problem, but it is also the heart failure. We call this as diabetic cardiomyopathy, where there is no obstructive cardiovascular disease, but people develop heart failure. So purely because of the benefits of empagliflozin on the heart failure alone, there is a reduction in the all-cause mortality. Next. Now, the CV safety trial, and as we all know, this is something which the ADA started asking for post the saga of rosiglitazone increasing the heart failure. From 2008 onwards, whichever new molecule was launched into the market, the ADA wanted, our US FDA wanted a CV-OT trial, as in a CV safety outcome trial for all these molecules. And needless to say, all the molecules which were launched post that, DPP-4 inhibitors or the SGLT2 inhibitors, there is a plethora of study looking at the CV-OT like EMPA-REG, Canvas, Credence, Declare-TIMI. So all these studies showed that there is no increment in or no adverse effects on the heart due to these molecules as a group effect. Next. So put together all these evidences that we have in front of us for SGLT2 inhibitors, the beneficial effect on the glycemia, the beneficial effect on the metabolic parameters like a reduction in systolic blood pressure, diastolic blood pressure, cholesterol, the adiposity, the central adiposity. Given all these benefits, it is not a surprise that all these evidences made the international guidelines to change. No longer we have a stepwise approach of starting with metformin, adding on sulfonylurea, etc. Now we have a situation where, depending on the patient right in front of us, we can choose the molecule whichever is most suitable for that patient as a first-line therapy. It need not be metformin, it could be an SGLT2 inhibitor, it could be a GLP-1 receptor agonist. And what has changed with the ADA EASD 2018 guideline is that when people who are diagnosed with type 2 diabetes, they are drug naive, or patients who are already on metformin, irrespective of the HbA1c, this is very important, irrespective of the HbA1c, if they have an atherosclerotic cardiovascular disease, that is, they have had an established atherosclerotic cardiovascular disease, or they are at a high or a very high risk of cardiovascular disease, then they qualify to be started on either SGLT2 inhibitors or a GLP-1 receptor agonist. Primarily, what it means is we are not looking at molecules which will just bring down the glycemia. We are now looking at molecules which will have an add-on benefit. As we all know, people with diabetes, the major killer is the cardiovascular mortality and cardiovascular morbidity. Therefore, if the molecules which we use to treat type 2 diabetes have got an additional benefit by reducing the cardiovascular morbidity and mortality, then these drugs are clearly preferred over the older agents. And that's where the guidelines change, which said these people who have got an ASCVD or a high risk of cardiovascular disease risk, they can get started on SGLT2 inhibitor or a GLP-1 receptor agonist. With those thoughts, I will leave my colleague to take the next session to talk about the cardiologist perspective regarding the SGLT2 inhibitors. Thank you, one and all.
Thank you, Dr. Narayanan.
Hello.
Yes.
Hello, are you able to hear me?
Yeah, but your slides are not visible.
Yeah. Are you able to see the slides? Hello.
I do not know.
Okay, now I will share it.
Yeah. You can share the screen, sir.
Okay. Okay.
Yeah, fine. Now you can start.
Good evening to all. This diabetes mellitus, it's with heart disease as well as kidney is a vicious cycle. So type 2 diabetes mellitus will cause heart failure, and heart failure, it will precipitate the type 2 diabetes mellitus, and heart failure itself can progress the disease of diabetic kidney disease, and type 2 diabetes mellitus will produce a diabetic kidney disease. But this both disease will cause sodium retention. This is the basic principle here. So in 1970, sodium glucose co-transmitter receptors is founded. And after that, in 1994, the researchers found that sodium glucose co-transmitter inhibitors may be useful for the cardiorenal failures. After that, there is a progression from 1994 to 2008. Only the drug molecule came out. And what is the mechanism? This is a normal glucose absorption. The SGLT2 receptors drives sodium coupled glucose into proximal convoluted tubule cells. From there, it returns to the blood through GLUT2. From that, potassium exchanged by energy dependent pump. This is a normal mechanism. So glucose is reabsorbed from the tubule to tubule cells and blood. In what happens if there is a SGL2 inhibitors? It inhibits the receptors. So the glomerular filtrate contains more glucose as well as the sodium. It will not absorb into the proximal tubular cells. So there is a what happened? There is a reduction in extracellular fluid volume, increased concentration in tubular fluid. Okay. What happened in heart failure and with the diabetes mellitus? There is in myocardial cells. What happened? Active NHE cell receptors. There is a increased sodium excretion that will happen. Intracellular sodium increases. This will causes entering into the mitochondria and produces reduced ATP as well as increased calcium output. This decreased ATP will cause the sodium potassium ATPase receptors and reduces the sodium potassium exchange. So sodium is increased. Because of that one, intracellular sodium is more and interstitial sodium is more, that causes edema. If it is SGLT2 receptor, what will happen? The entry of sodium is restricted, so increased calcium in the intracellular and ATP is increased. This will excrete the sodium outside. So more sodium will be go into the interstitial fluid and excreted outside. So with this background, there is exploratory data show that SGLT2 inhibitors may have multiple cardiorenal benefits. So 4 studies, EMPA-REG and CANVAS program declared TIMI58. These are all shows there is a recurrent hospitalization as well as cardiovascular death, kidney outcomes will be reduced major, that is around 30 to 40%. And EMPA-REG outcome trials, cardiovascular outcomes and death from any cause, it's a 14 to 30% reduction in cardiovascular death or hospitalization from heart failure. In Framingham heart study, because of diabetes, there is a high rate of heart failure in patients with diabetes over 30 years of follow-up. You see here, there is a cardiac failure is a major event in Framingham heart study. The heart failure is a more common outcome than myocardial infarction, stroke, and death in diabetes mellitus trials, various trials. And what happened? Effect of more or less intensive glycemic control on MI and heart failure resulting in hospital admission or death. This will show the favors more intensive control favors the reduction in heart failure as well as myocardial infarction. Heart failure outcomes in clinical trials of glucose lowering agents, in various agents used to found what is the usage. Here you see the hazard ratio is very much reduced in SGLT2 inhibitor usage EMPA-REG trials. And there is a evidence for benefit of SGLT2 inhibitors is on heart failure risk in patients with diabetes. EMPA-REG outcome trial, that is screening 11,000 patients around and randomized and treated 7,000. Placebo is around 2,300 and EMPA will be on 10 milligram 2,300 and EMPA 25 milligram is 2,342. What are the key inclusion criteria? Adults with type 2 diabetes and established cardiovascular disease, 10.1% had heart failure at baseline. BMI is less than 45 kg per meter square, HbA1c around 7 to 10%, and GFR is more than 30 ml per minute per 1.73 square feet. So here, if you compare here, there is a placebo to EMPA, there is a hazard ratio reduction is more in EMPA. So this clearly shows that the SGLT2 inhibitor is useful in the diabetic patient to reduce the glucose. The SGLT inhibitors affect multiple pathophysiological aspects of heart failure. What happened? This is increases in natriuresis and improved kidney function and cardiorenal physiology, reduced preload, afterload, and reduced LV wall stress. So reduction in interstitial edema. So what are the drugs used to treat the patients? This various drugs, therapies that only prevent heart failure, therapies that only treat established heart failure, therapies that best treat and prevent. So in this, the only drug for useful in the prevention is SGLT2 inhibitors. And the guidelines, what is the guidelines says is in 2019 ESI guidelines, as well as 2019 ACC-AHA practice guidelines shows that there is a start with or add on consideration can be given to an SGLT2 inhibitor. Both guidelines says that start with the SGLT2 inhibitors. So with this Emperor heart failure studies clearly shows that its recommendation of the Emperor trials of Empagliflozin in patients with chronic heart failure reduced as well as preserved ejection fraction. The reduced ejection fraction is less than 40% and preserved ejection fraction is more than 40%. There is in reduced ejection fraction, NT-proBNP is also a matched it's a parameter, one of the parameters. And the drugs, adequate drugs will be treated on such as the ACER, beta blockers, diuretics, and the statins, all adequately given in these both groups. In preserved ejection fraction, the NT-proBNP level will be fixed around 300 picogram per ml. If the patient got AF, there will be more than 900 picogram per ml. This is a criteria. So, Emperor with the preserved trial, in this, there is a total of 2018 patients and placebo as well as comparative with the EMPA 10 milligram. And here also with reduced ejection fraction. Here, this is 3,730 participants. So, all over the world, it's conducted. This in this pink color shows participation in both trials, that is reduced ejection fraction as well as preserved ejection fraction. The light blue color is only the preserved ejection fraction. Dark blue is for the preserved ejection fraction, reduced ejection, sorry. And conclusion, with this conclusion, the Emperor reduced and Emperor preserved trials will determine the efficacy and safety of EMPA in patients with heart failure with reduced ejection fraction and heart failure with preserved ejection fraction respectively. The effect of EMPA on symptoms, exercise capacity, and patient-reported outcomes in patients with heart failure with reduced ejection fraction or heart failure with preserved ejection fraction are being investigated in the Imperial reduced and Imperial preserved trials. And there is this evaluation of the effect of sodium glucose co-transfer to inhibition of the EMPA on morbidity and mortality of patients with chronic heart failure and reduced ejection fraction rationale for and design of the Emperor reduced trial. Here you see this Emperor reduced top line results, EMPA beneficial in heart failure with reduced ejection fraction with or without diabetes. This is a very good paper. This is the actually New England Journal, an original article. It is by the Ms. Parker. He is also presented this in the ESA Congress 2020, and this Emperor reduced trial effect. Milton Parker, he said, what is the endpoints? The primary endpoint is composite of cardiac death or heart failure hospitalization is very much reduced, and first secondary endpoints total, that is first and second recurrent heart failure hospitalization, and second secondary endpoint slope of decline in glomerular filtration rate over time. So the Emperor reduced trial showed that EMPA is superior to placebo, improving heart failure outcomes among patients with symptomatic stable heart failure with reduced ejection fraction. And the goal of the trial was to assess the safety and efficacy of EMPA with symptomatic heart failure with reduced ejection fraction, irrespective of diabetes status. What is the study design? Here, the patient randomized in a 1:1 patient to either EMPA 10 milligram or matching placebo. All the patients are receiving appropriate treatment for heart failure. The total screened number is 7,220. Total number of enrollees 3,730. Duration of follow-up 16 months. Mean patient age 67 years. Percentage of females is 24%. Inclusion criteria: age is more than 18 years. Chronic heart failure, New York Heart Association functional class 2, 3, or 4. Left ventricle EF is reduced. This is less than 40%. That is a margin. It's a reduced ejection fraction is less than 40, and more than 40 is a preserved ejection fraction. Hospitalization within 12 months. N-terminal P-type natriuretic peptide, it will be more than 600 picogram if the EF is less than 35%. If the EF is more than 35%, 2,500 picogram per ml. If the concomitant AF is present, then above threefold are doubled. Exclusion criteria: stroke, IST, ischemic transient ischemic attack, acute coronary syndrome, or heart transplantation, or cardiomyopathy, valvular heart disease, or acute decompensated heart failure, CRTD, or implantable cardioverter, ICD. all populations. This is white as well as Asian populations included, North American, Europe, Asia, Latin America. As a NIHA functional class 2 also included, and mean LV ejection fraction rate 27%. 50% of the patient will be the type 2 diabetes, and the estimated glomerular filtration rate is less than 60, around 48%. Medications, AC inhibitors, RNA, and mineralocorticoids, beta blockers, ICD patients 31%, CRT 12%. The primary outcome, cardiovascular death and hospitalization with EMPA with the placebo was 19.4% versus 24.7%. The cardiovascular death will be around 10% versus 10.8% in placebo group. Recurrent hospitalization will be 13.2 in EMPA and 18.3 in the placebo group. So this clearly shows that the primary endpoint is 25% reduction, and secondary endpoint is 30% reduction, and secondary endpoint will be 50% reduction. And EMPA-REG trial has major implication for clinical practice. The EMPA-REG trial with EMPA will have a major impact on the management of patients with chronic heart failure and a reduced ejection fraction, whether or not they have diabetes. There is now compelling evidence that SGLT2 inhibitors should now be currently recommended treatment for this disease. And EMPA-REG total hospitalization of heart failure, first and recurrent heart failures, compared to placebo, there is a reduced in EMPA group. And related cardiovascular disease, reduced safety also. And does EMPA lower the risk of CV death or hospitalization in patients with heart failure? Among patients receiving recommended therapy for heart failure, those in the EMPA group had a lower risk of cardiovascular death or hospitalization for heart failure than those in the placebo group, regardless of the presence or absence of diabetes. So the secondary outcomes, total hospitalization 388 versus 553. Composite renal outcome, that is chronic hemodialysis, renal transplantation, 1.6 versus 3.1 in placebo group. All-cause mortality 13.4% versus 14.2%. New onset type 2 diabetes among patients with pre-diabetes. And change in hemoglobin A1C between baseline and week 52 is 0.28 versus 0.12%. This comparison between this placebo, EMPA plus placebo. Systolic blood pressure reduction is 2.4 versus 1.7. And interpretation, the results of this trial indicate that EMPA is superior to placebo in type 2 diabetes mellitus. Outcomes among patients with symptomatic stable heart failure with reduced ejection fraction and baseline guideline directed medical therapy irrespective of diabetes. Benefit is primarily driven by a reduction in heart failure hospitalization. There was also a benefit in renal outcomes. This is a very important trial and mirrors similar findings from the DAPA canvas dapagliflozin. Even patients with severe LV dysfunction appear to be benefited. Even though SGLT2 inhibitors were introduced as type 2 diabetes management, EMPA-REG outcome trial and others indicated clear benefit irrespective of management. This trial enrolled a dedicated heart failure population and conclusive show a better patient population irrespective of diabetes mellitus. So what is the mechanism here? What happened to the heart failure patients? It's a reduced cardiac preload, shift to ketone metabolism, adaptive cellular reprogramming, inhibition of sodium hydrogen exchange, improved endothelial function, reduced cardiac fibrosis. So what is the research, evaluating research and insights? The effect of EMPA versus placebo on body composition in patients type 2 diabetes mellitus and myocardial infarction, subgroup analysis with the trials. The effect of EMPA as add-on therapy on transtubular potassium clearance gradient in patients with type 2 diabetes hospitalized for acute decompensated heart failure. The effects of EMPA on arterial stiffness, endothelial function, and ventricular arterial coupling in type 2 diabetes mellitus 1 year follow-up. So this SGLT2 inhibitors, there is a favorable effects as well as unfavorable effects will be genital infections. This is more common, and diabetic ketoacidosis. Some patients will have the diabetic ketoacidosis and hypoglycemia. Some patients will have prevention of incident and treatment of established heart failure. This is preventive aspect. And preserve renal function, reduction of major adverse cardiovascular events, reduction of BP and weight loss, and improvement in glycemia. So the risk and benefit is, the benefit is more SGL with SGLT2 inhibitors. So SGLT2 inhibitors provide effective management of cardiac and renal dysfunction in type 2 diabetes mellitus. Improved management of heart failure with reduced ejection fraction without diabetes mellitus. SGLT2 inhibitor is renal protective in patients with CKD with and without diabetes mellitus. Thanks. Thank you, sir.
Thank you, Dr. Manohar, for this presentation. There is a question from audience.
Yeah.
The question is, after this EMPA-REG trial, do you think empagliflozin is a game changer compared to the metformin when it's compared to the metformin?
For type 2 diabetes mellitus, definitely.
Type 2 diabetes mellitus, yes.
Yeah, in type 2 diabetes mellitus with heart failure or cardiovascular disease, it will be definitely game changer.
Okay. Yeah, there is a question, Dr. Narayanan.
Yeah.
There is a question from the audience. Just a moment. Yeah. Can we prescribe SGLT2 inhibitor in patients without established CVD or having multiple CV risk factors?
Of course. See, as we saw from the EMPA-REG trial, the people who were recruited into the trial, either they have already had an obstructive cardiovascular event like an MI, or they have just had high risk factors for cardiovascular disease. It could be a single vessel disease, it could be heart failure, it could be other risk factors which were present. So this was a trial which included people who have already had a high risk for cardiovascular disease, and the trial showed beneficial effects in patients with type 2 diabetes on the cardiovascular morbidity and mortality. So definitely yes.
Okay. Thank you. So there is no more questions. So we are just stopping the session, sir. We're just concluding the session. Okay. And on behalf of Lupin, thank you, Dr. Manohar and Dr. Narayanan, for sharing your valuable experiences and your wonderful presentation. Okay. And we'll see you in the future meeting. Thank you very much.
Thank you.
Thank you, everybody. Thank you.
Yeah.
But one suggestion, sir. Type 1 diabetes mellitus, it should not be used. The SGLT2 inhibitor should not be used. It is
should not be used. Yes, for type 1. Yes. Thank you.
Thank you.
Sir. Thank you. Bye.